Thank you. So we're going to, for this next session, we're going to be focusing a little more on the future. So we've heard a lot this morning about how we've got to where we are at the moment, and really the idea of this next two sessions is to focus on the next period of time. This initial session, we're going to be focusing on the sort of more short to medium term future, the next 3 to 5 years in terms of key priorities. We'll be looking at the treatment pathway and importantly bringing in patient perspective as well. We've heard a lot about our perspectives as a clinicians, but it's really important that we're looking in the broadest sense as well. So I'm going to introduce all four speakers together, and then I'll let you all pass on from one to each other in the interest of time. So starting off, Martin's just joined us on the stage. So Professor Martin Kaiser is Professor of Haematology at the Royal Marsden ICR. Huge interest and expertise, particularly around genomics and high-risk myeloma, but also in imaging, but also, particularly in the last few years, a real focus on how we can translate all the developments that we've heard about and increasingly hear about into clinical practice in terms of introducing therapies to not just through pharma-sponsored clinical trials, but also through academic studies. So we'll be hearing about his perspective, looking at things from an England perspective. Kerry Bygrave, obviously you know very well, consultant haematologist in Cardiff and chair of the UK Myeloma Society, with an active interest also in imaging and MRD, and on the radar MRD subgroup as joint lead of that. Jennifer Travers, consultant haematologist in the Beatson in Glasgow, with a particular interest in myeloma and plasma cell disorders, and actively involved in many clinical trials, as well as being the clinical lead and laboratory director. And then Sarah Lawless, consultant haematologist at Belfast City Hospital, with interest in both myeloma and lymphoma, and representing Northern Ireland on the UK Myeloma Society since 2017, again with a particular interest in plasma cell disorders and developing clinical trials in Belfast. So we're hearing from each in turn, starting off in England with Martin.
Thank you. Thank you very much, Matt. Thanks for a very kind introduction and for the invitation to speak. I have to admit, if someone had asked me 20 years ago that will I ever be standing on a stage and present the perspective of England on the stage, I would have not necessarily believed them, but the chat over lunch showed me that I'm not the only one actually who was actually flying under a different flag, maybe. Anyway, it's of course an honor to be here. It's also great to speak after such a great speaker like Amgen. I also didn't quite realize I actually grew up just down the road from the Grünenthal factory that invented thalidomide, of course, under all the bad and worse circumstances at the time. But I was driving past it nearly every morning on the way to school. And again, that now has a weird full circle to coming back. I don't know. It's at least a good one. Anyway, this is hopefully a bit of an outlook on the next 3 to 5 years that makes sense. These are my disclosures. When thinking about the title, I was thinking about, firstly, of course, what is likely going to change. And I think there are things that we can relatively predict because we know which clinical trials are going on at the moment, and we are getting some sense of how our patients have been doing on this. But I think there is a question that can overlap with that question, but it doesn't necessarily have to overlap, is where is the unmet need for our patients? And what would we like to change for our patients, even if these developments are happening, which are positive overall. But actually, there are gaps still. And I guess the question that I would like to address is, well, how can we achieve that we really also not only fill in the things that we know are coming, but the ones that we feel are remaining gaps as well. And I think the things that are coming are, of course, coming mostly through the clinical development routes of industry, and I think there has been fantastic progress for our patients for that, and we're all very, very mindful of how greatly that has impacted the outcomes of our patients over time. I think this is a pathway that many of you see at meetings in a much busier form, but I've kind of like boiled it down into the things that we're really at the moment using. So when you see this pathway diagram at other meetings, it is full to the brim, and actually when you boil it down to what is really in use at the moment, it's pretty much now a one standardized treatment for the transplant-eligible patients, DARA-VTD, and a transplant, of course, and then the transplant-eligible, and then all the other lines. I can't claim completeness here. I hope if any errors, please forgive me here. But I think the things that we can probably predict over the next 3 to 5 years is that there has been a readout already for several anti-CD38 VRD induction regimens and treatments for non-transplant eligible patients. So they look very promising over just a DRD, and we will have to wait what happens, but it's probably that this is going to change. I think it was probably mentioned in the morning that the belamaf combination therapies have also had very good readouts in a really challenging triplet against triplet readout, which I personally still find is the new era that we're entering that is fantastic. And they're heading to early relapse lines. I think we're probably over the next years getting the feeling that we might see anti-BCMA T-cell engager bispecific antibodies also coming into that space. And of course, we could spend a whole meeting just talking about how that will look like in second line, although a lot of it would be speculation at the moment because no one knows the data yet. But we do know data, of course, about anti-GPRC5D T-cell engagers in relapse refractory myeloma, and there is certainly a very good rationale for actually using these drugs in patients in later lines of relapse. So I think that's relatively the way that we can predict that things are going, but I think then there are also uncertainties that, despite good data being out there, are maybe less clear for us yet as to when they come. They might come, but it's probably a bigger question mark about the timing. So the transplant eligible pathway, of course, had a very striking readout by the Perseus trial, but there are already interesting developments, of course, by the FDA label differing from the EMA label, and actually certainly at the moment, when we look back at the time when lenalidomide got licensed, there was definitely a requirement for a long follow-up for overall survival to really be consistent with reimbursement. And of course, everyone who sees the curves is very, very impressed, but we're not there yet that the overall survival is in the right place. And I think that leaves us definitely in England with an oddity, which I hope very much that we can overcome, that we are giving Dara-VTD when we do know that thalidomide, we've just heard it in the talk before, is actually an ancient drug, and it's causing what I would call a very silent toxicity. I think people are very happy. I mean, it sounds, don't take me, by the word, it's actually a cynicism that we are more happy to tolerate neuropathy in patients than tolerating other toxicities, because it's, only the patient feels it. It doesn't cause any trouble for us, it's only the patient that feels it. And if I can be honest around the room, I know we have tried our academic routes of actually trying to get from Dara-VTD to Dara-VRD. And for a long time, we were told it's not possible because there isn't a license. There is now a license for Dara-VRD induction or anti-CD38 VRD induction therapy. If there are routes, if especially industry colleagues are around the room that know that it will take a while for the maintenance part to come through, please seek us, seek Myeloma UK, so that we can find a solution to stop having to use thalidomide in our patients' upfront treatment. Maybe this is in the making already, maybe it's all confidential and we just don't know about it, but it is an oddity that I feel we shouldn't really be tolerating much longer in our pathway. Of course, there are CAR T-cell data that are looking very, very good in early relapse, but there are barriers to that being adopted at the moment. This might change over time, but I think it's still an uncertainty with the bispecifics, of course, looking very good, probably in early relapse as well as to where we will be ending up. What is not in this diagram are, however, all of the regimens that were never either submitted to NICE or that were still going through weird regulatory pathways, such as venetoclax. It's a very another thing on my mind. It's a drug I would love to see somewhere in the pathway. It still doesn't have a license, so it has never even had a chance to come to NICE. And I think there are quite a lot of things on here that are also not mentioned here, but combination regimens that are now going full generic combination regimens that will never have a route of finding into our pathway via NICE. And I think there's really clearly a societal requirement that we do consider a little bit more how we can make use of these treatments, because regardless of the changes that are ahead of us, the pathway, and I think I just wanted to make really clear, we're all grateful for all the progress that has been happening. I think every single drug that's coming on, and it has come on over the last years, has been a huge success in terms of outcome for our patients. But the pathway as such still remains, in some sense, a one-size-fits-all pathway. It is defined by lines of therapy, and in many lines there are limited choices. And there is a limited recognition, I would say, overall, of patient heterogeneity. And I think we should really make more of a reflection, and we do that on a daily basis in many forms in how we deviate from treatments that are by the book, but we need more formalized recognition of the patient heterogeneity, because that is needed to jointly define the care priorities with every single patient. And more treatment choices are needed to enable actually to really enact this joint decision-making into making different choices for therapies. So one of the heterogeneity that I want to focus on mostly is high-risk myeloma. Although I start with a slide, it doesn't have to do directly with high-risk myeloma. I'm actually just using the example of a younger patient, 60-year-old patient, that we now all see in our clinics, and I think we all have very similar discussions with them. They're asking us, am I on treatment for the rest of my life? What are the risks of a treatment holiday? Am I overtreated? How long have I got? Simple questions, difficult to answer. There will be an updated risk definition by the IMS and the IMWG. I'm calling it 2025. It might well be 2024. It might well be 2025. It will actually mostly be based on the co-occurrence of 2 or more high-risk cytogenetic abnormalities, and or the presence of a biallelic deletion 1p and or any abnormalities of TP53. And then there is an odd extra group that is defined just by beta-2 microglobulin over 5.5 without renal impairment. The later group I'm not very convinced about, but I think about the genetic definition, we should not forget it has been a huge contribution by UK academic research that has led to this definition. You will unfortunately not hear that at international conferences necessarily that much. But the first concept was really shaped by Myeloma 9 in 2012, and my great colleague Kevin Boyd actually is the first author of that publication. From that time, it was that concept was confirmed to be highly consistent in Myeloma 11 later down the line, and that actually was giving us a head start, really. That's why it was implemented in MAC 9 already a good nearly 10 years ago, and implemented in the RADAR trial as well as a risk stratification model. If you actually look at the frequency of patients that you identify by double hit, so 2 or more high-risk markers versus just the biallelic deletion 1p or just TP53, it is the majority. Over 95% of patients you identify by double hit. Now, what will this updated definition do? It will raise the focus globally regarding the heterogeneity and the unmet need of the population, on the need of more and better diagnostics for myeloma patients, and an opportunity towards more informed joint decision-making. And why is that so? Well, there's other data also coming out that's already very interesting, especially, for example, from the MASTER trial here, which really did develop a new concept, especially for standard risk patients. Patients stopped treatment based on MRD negativity in this trial, and there's now 5-year follow-up nearly that shows that of the standard risk patients, very, very few relapsed, although they actually stopped therapy several years before that. It is not a concept that works very well for high-risk patients, but it is definitely demonstrating us ways forward by using more diagnostics. Now, how do we address the outcome of high-risk patients? And I think this is the Optimum MAC 9 trial, which I was very, very happy to lead with Matt together, but actually also with lots of real great collaboration around the country, really focusing on improving the outcomes of patients, specifically by treatment post-transplant here. But I think it's very important to reflect that this trial was based on an unmet need analysis done by Myeloma UK 2015-2016. It was informed by research that was dating even earlier back. It was academically designed and delivered from 2017 onwards in the NHS. And this is now the 5-year outcomes. I would like to ask you not to post this. This is actually something that we're going to only show at ASH in several weeks' time, but the abstracts are now published, so you can see the numbers already online anyway. So this is the difference that you get in progression-free survival between the Myeloma 11 external comparator treatment and the optimum treatment for all ultra-high-risk patients. And most importantly, this is the uplift in overall survival that you get at 5 years between these two groups. I don't doubt that you will see at the moment a commercial trial that will have the same kind of impact of uplift in overall survival that early on in follow-up. Now, that of course gives us a new perspective together with the other data, external data, for example, from MASTER, about that we really can think probably in the future about stratifying treatment for our patients. But for that, we need laboratory diagnostics, we need imaging, and we need access to MRD diagnostics. And I think we are starting definitely as a society, the UKMS, to work on better policy and better access, because that is something that actually we mostly have ourselves to organize ourselves for. But how do we get these results from UK research, from NHS research, really to patients? Well, we did actually stick our heads together in UKMS and formed a new subgroup, the Pathway Optimization Group, in close collaboration with Myeloma UK. And we actually really tried to identify gaps, real gaps, not anything that overlaps with the NICE process, but something that can benefit ultimately all stakeholders together in optimizing treatment. And the first experiences are unfortunately sobering so far, although it is work in progress. We have made an application for Mark 9 via a route that is possible for some treatments to enter the NHS route, and it is at the moment still on hold and is awaiting further input from us. We've also made a second application for a generic combo, which would never be taken forward, and it's all at the moment an ongoing process. But what emerged is that there's still a clear unmet need for a defined route for patient and physician community to contribute to the diagnostic and treatment pathways, especially to address the gaps that are left by the NICE process, which is very good in many regions, but actually does not completely fit the needs of our patients. So that's really a continuing ongoing work, and we're very, very grateful for all the feedback and work together here in the group to address that. So with that, I would like to thank you.